Good morning, everybody. Thank you for the kind introduction, Maria. I'm very glad to open the CME session, as the CME team has been working for the last 1 year to plan this CME session for today. I'm honored to introduce our plenary speaker, Dr. Rayyaz Malik. Dr. Malik is a graduate from University of Aberdeen, and he completed his PhD from University of Manchester. He's a professor of medicine at Weill Cornell Medicine in Qatar. His clinical research involves cardiomyopathy and neuropathy. His particular expertise is in diabetic neuropathy. He's a co-editor and has co-authored book chapters and has published over 150 articles in peer-reviewed journals. Dr. Rayyaz Malik.
Assalamu alaikum, everybody. Right, so we'll start with dogma, which is my title. What is dogma? Well, it's what holds back progress, I believe, because it's a set of beliefs held by a group or organization which others are expected to accept without argument. And we, as doctors, are the worst people in the world, right? Because we believe we know everything about everything in our little world, and we won't accept anybody else's kind of approach to this. So, where do I start my journey? I start my journey actually as a medical student in Aberdeen, where I'm set a project to look at something called diabetic neuropathy, which I know nothing about. And the first thing that really hits me is that when we have a patient with diabetes, they develop complications, and they get eye complications, they get kidney complications, and they get nerve complications. For the eye and the kidney, we've got amazing methods to really detect disease very early, right? So, we can do retinal fundus photography, we can do OCT, kidney disease, microalbuminuria. Still happy, actually, with a monofilament exam, which is very good for detecting advanced disease, but it's terrible for detecting early disease. So, what is the consequence of family physicians, even physicians sitting in the ivory towers, detecting disease at this stage? Is it good? Bad? Very bad, right? Why? Can we play this? So this is just to wake you all up. This is the reason why I have dedicated the last 20 years of my research to this, to prevent this, because I believe fundamentally we've been doing it wrong, okay? That we've been missing the boat. And Machiavelli, so Ashfaq Shuhaib has read The Prince, because you know why? Because all megalomaniacs read The Prince. Right, all people who control other people read The Prince, but I don't, and I had just read this little bit, right, which is, as the doctors say of a wasting disease, to start with, it is easy to cure but difficult to diagnose. After a time, unless it has been diagnosed and treated at the outset, it becomes easy to diagnose but difficult to cure. And that's the core thing that we talk about, prevention is better than advanced disease, okay? Okay. So now, how do we address this? Well, we address this by going back in history. And what I want to take you to is somebody called Marcus Aurelius, who was a famous, actually, Caesar. And he said, we need to learn to measure what we value, not value what we can easily measure. Right. So, challenging the dogma. What we're doing now is diagnosing the condition too late. And what I want to do is change that, okay? And I want to prevent this. So in 2001, we had a crazy idea, right? Which was that we're going to look at diabetic neuropathy, which we know is a disease of the extremities. But what we're going to do is actually, we're going to measure neuropathy, neurodegeneration, which happens in the feet, in the eyes. Can you imagine an endocrinologist suggesting that to the neurologists? It was like, Jesus, this guy doesn't know what he's talking about. He doesn't understand the basic concept of what neurodegenerative disease is. Look into your eyes and tell you whether or not you have neurodegeneration. And what was that technique? Well, the technique was something called corneal confocal microscopy. Remember that, CCM, right? So this is rapid, totally non-invasive, and is able to image nerve fibers in the cornea without having to take a piece of cornea out and take it to the lab. Can we play that? And this is as simple as how it works. So you do have to just set the machine up, but literally a little bit of local anesthetic to stop people from blinking, really. And literally then it's like a scan, a CT scan at microscopic level, which is able to identify the nerve fibers in the cornea. Okay. Next, you take an image. You see these lines. These lines are actually nerve fibers. They're C nerve fibers. And what we do is measure certain features. So the main features that we measure are corneal nerve fiber density, corneal nerve fiber length. Is challenging the dogma easy? No, right? But can we play that? For fun. I always say the good guys are these guys and the bad guys, the neurologists, Avengers, are the other side. That's me, not me really, but okay. So 2001, a colleague of mine describes from optometry actually that we can see these nerves. 2002, we get a grant from the Juvenile Diabetes Research Foundation in New York. 2003, we publish our first paper. What does that paper show? Well, it shows the following. 25 patients with diabetes with different severities of neuropathy. Okay? I'm not sure if this works. Yes. What you see here is mild, moderate, severe neuropathy. And what you see here are the corneal nerves, which are being assessed. So this is a patient with severe neuropathy. You see one or two fibers, lots of nerve fibers in the healthy control. And you see this progressive fallout. So just by scanning the eye, actually, within minutes, I can actually work out whether or not there is neuropathy, and most importantly, actually, whether it's subclinical. This here, you see, is very early, but yet already we're picking up nerve fiber loss. And then a lot of people said, oh, it's just the Malik lab producing this. Alhamdulillah. Now, like 15 years later, there's been multiple, actually, labs who've replicated our data, over 4,000, now actually about 15,000 patients, all showing the same 38 studies that we can use corneal confocal microscopy to differentiate healthy controls from people with subclinical neuropathy and then with diabetic neuropathy. Now, we also actually, everybody talks about AI, right? But we actually started using AI, and there was a very clever Palestinian engineer who helped us, Mohammed Daba, who actually developed a kind of deep learning method to quantify these nerve fibers. So you can imagine when we had these nerve fibers, my poor postdocs were having to trace all these nerves, right? But what we now have is a deep learning method which literally within like seconds is able to differentiate healthy controls from people with diabetic neuropathy with 100% sensitivity and 95% specificity. I don't need the history from the patient even. Honestly, I can just take the patient, scan them, and I get that. I get that as an answer. And that's the power of AI, particularly in imaging. The other thing that we want to know is, can I take a patient with diabetes today and predict whether they will develop neuropathy in 4 or 5 years' time? Well, we got a grant actually from the NIH, sitting in Manchester, which was a kind of a big thing. But we did this grant. Actually, Bruce Perkins from Toronto was one of the collaborators. And what we did is we took patients with diabetes, 260 out of almost 1,000 patients had no diabetic neuropathy at that time. We then followed them over a period of 6 years. A proportion developed diabetic neuropathy, about a quarter, right? 23%. So then when we looked to see what was it that predicted these people who didn't have neuropathy, who didn't develop neuropathy, well, things like, of course, risk factors like having poorer metabolic control, being more overweight, predicted it, but actually corneal nerve fiber density. So there was, if you had a lower corneal nerve fiber length, less than 14, you actually had a 80% risk of developing diabetic neuropathy 5 years later. And then kind of actually, I didn't get bored with diabetic neuropathy, but we thought, if it works for diabetic neuropathy, maybe it'll work for other peripheral neuropathies. And in fact, we started in 2003, but you can see there's multiple conditions. Virtually every peripheral neuropathy you can think of, CCM has now been used by us and others to show, like whether it's idiopathic small fiber neuropathy, whether it's HIV neuropathy, amyloid neuropathy, even fibromyalgia. And I'll show you the data where we've used corneal confocal microscopy and it identifies neurodegeneration. So this is one example. HIV. We know people get neuropathy, and also from the drugs actually that we use, they also can get a neuropathy. So we actually did a study where we took patients with and without sensory neuropathy. And what we showed is corneal nerves, there were less nerves in those people who had neuropathy compared to those who didn't, compared to healthy controls. There was also, we know that HIV has got an immune component, and within the cornea, actually, there are these immune cells that we can see. We measured those, and you can see that those were also higher in people with HIV sensory neuropathy. A hereditary neuropathy called Friedreich's ataxia, you may be aware of, which is this debilitating condition where, young people are put in wheelchairs by the time they're like, 20, early 20s. What we, in actually working in New York, we got a big series of these patients that have been referred from all over. We actually did CCM in these patients. And what we found is that CCM picks up actually loss of corneal nerve fibers, fiber density, fiber length, and branch density in these patients. Moreover, the neurologists will measure patient function, and they do this through the SARS score and the FARS score and the SARA score. And what we found is actually there is a very good correlation between corneal nerve loss and function, of how well the patient gets out of a wheelchair, how they function. So there is a correlation between corneal nerve loss and physical disability. Moreover, we know that there is it's a genetic condition. There are these GAA repeats that cause this condition. Is there an association between the number of GAA repeats and corneal nerve loss? Yes, there is. So there is a mechanistic link between the corneal nerve fiber loss and changes. The other big neuropathy that neurologists will come across is CIDP, chronic inflammatory demyelinating polyneuropathy. And I remember having this conversation with a German colleague, and he's a neurologist and he's a German. So you can imagine the two together are not a good combination, because they are very dogmatic, right? So he said to me, Rayyaz, there's no way, just by the name, inflammatory demyelinating neuropathy, do you not understand, right, that, this is a demyelinating condition. It cannot be axonal, and it cannot cause, that's a bad German accent, but it cannot cause small fiber changes. Guess what? They went away, and actually they did the study because they wanted to disprove me. Alhamdulillah, right? They did it, and he came back to me and said, Rayyaz, you're right. I said, yeah, as humble endocrinologists, sometimes we get things right. So we actually showed that there is less nerve fibers, small nerve fibers, which was not actually something that people would accept in chronic inflammatory demyelinating neuropathy, and MGUSN, and multifocal motor neuropathy. But there are also more cells, which you'd expect because it's an immune-mediated disease. And then they actually went on and showed that loss of these nerve fibers, if you have a certain threshold, which happened to be in terms of cell number, if you had more than 30 dendritic cells in the image at baseline, you could actually predict with almost 100% sensitivity and specificity whether or not the patient was going to progress or remain stable. Fibromyalgia. I know, honestly, as a junior doctor, I always used to think that's the diagnosis of the destitute, right? I was told that by some people, but I didn't kind of, but you know, it's a funny condition, isn't it, fibromyalgia? Some people you kind of go, well, have they got it? Haven't they got it? Is there an objective measure? Well, apart from in the past when the people, rheumatologists used to kind of do this and say, oh yeah, you've got fibromyalgia. Is there a basis for it? And well, we actually, again, with German colleagues, looked at this. And what did we show? Well, actually, there is a significant proportion of people with fibromyalgia, probably up to 50%, who have small fiber neuropathy. They have neurodegeneration. So they did detailed neurological evaluation that showed that there were abnormalities. They did something called, it's like they insert little microelectrodes into actually the nerve fibers, and they looked at spontaneous activity. They found that there was an abnormality. They did skin biopsy, and they showed there was an abnormality. And guess what? They did corneal confocal microscopy, and they showed exactly the same, that there is a loss of nerve fibers in the cornea in fibromyalgia. Long COVID. Who believes in long COVID? Yeah? Can you objectively measure it? Not really, because patients come in and they say, I've got long COVID. Well, we actually did a study with some Turkish colleagues where we took patients with long COVID. We, based on the long COVID questionnaire, which is a nice questionnaire, and guess what? CCM, there's a loss of nerve fibers in those with long COVID, and there is an increase in immune cells 3 months after they've got it. So there's something going on in terms of neurology, and so we now have an objective measure. And we got this attention score. I never even heard of it, but a colleague of mine said, wow, Rayyaz, that's really good. Apparently 1500 is very good. So I know what you're thinking, right? How much time have I got left? Who's the timekeeper? Got plenty? Okay. I know what you're thinking. What are you thinking? God, look at all these pathologies, right? It's shown me there's less corneal nerve fibers. This is where actually AI comes into this. And this is our recent data. We then thought, you know what? We know there's less nerves in HIV, in CIPN, in CIDP. But how do we differentiate? And that's always the neurologist came back to me. They said, oh, yeah, Rayyaz, you've shown this, but how does that help me in the clinic when I've got a patient? How do I know that this is from HIV or from diabetic neuropathy? Well, we actually did the study where we took patients with CIDP, CIPN, diabetic neuropathy, HIV, and healthy controls. We then applied this amazing technology called VITS, which actually is Vision Transformers. It's an AI-based analysis of features on an image, right? And it's not like I was measuring nerve fiber density, nerve branch density, nerve fiber length. This actually looks at the image and not 3 features, but it looks at 2,400 features, right? And by doing that, it actually somehow, I don't know how, it's magic, right? It looks at the visual patterns and it determines from not just the actual numbers, but the texture, the shape, the spatial relationships, is able to now actually differentiate with almost 100% sensitivity and specificity which disease it is. And if you actually do this, you can see each of these clusters represents different neuropathies. And the computer can tell me with almost 100% sensitivity and specificity now that this is HIV neuropathy or whether it's CIDP or CIPN. We then, the NIH actually, we were successful in the first case. And then so we went back to them, we said, give us $1.5 million, right? And they said, okay, we'll give you 1.5 million. But first of all, can you show me that CCM improves with an intervention, right? So we've so far shown that it's good for diagnosis, right? But can we use this as a clinical trial tool? That's a problem, right? And that's where we have had a big issue with diabetic neuropathy, particularly because, as you know, there is no disease-modifying therapy that's approved by the FDA. And that's where, when I looked at the failure rate for diabetic agents for diabetic neuropathy, disease-modifying therapies, it's 100%, right? And every year I update this slide. It's 2022, 2023, 2024, 2025. And so there's no therapies that can actually help diabetic neuropathy. And I thought, you know what, the NIH are playing games with me. They're saying, yeah, we'll give you $1.5 million, but you've got to prove something that's impossible to prove. Alhamdulillah, then again, there is a God, of course. I was on call, I remember, in Manchester one evening, and he's actually an anaesthetist. Physicians, we never go in hospital after kind of, I don't know, maybe you do in Canada, but in the UK, as a consultant physician, my juniors do all the work. I just come in the morning and I kind of profess, right? So, but this particular, I won't digress too much, but this particular evening, there was a very poorly lady, and the anaesthetist insisted that the consultant should come in and assess the lady before she was going to be intubated, right? So I had to come in midnight, right? So then I'm finished. I look at the lady and she's almost dying, right? I said, look, please intubate her, right? So they intubated her. And then I'm walking back down the corridor and I come across Titus, who's actually a pancreas transplant surgeon. And we get talking, and my thing is CCM, right? And I said, oh, Titus, I've got this grant from the NIH, and I don't know what to do. He said, Rayyaz, look, I'm curing your patients with type 1 diabetes 3-4 times a month, right? I'm putting a new pancreas into them. Why don't we look at patients before and after? So we did. And actually, we published the data. And what we showed is that people who undergo type 1 diabetes, who undergo pancreas kidney transplantation, actually start to repair their corneal nerves within 6 months. And it starts going up and up and up after 36 months. You compare that to the other tests like skin biopsy, nothing works. Symptom, signs, nerve conduction, hardly changes until 36 months, right? So we now have a test, CCM, which is able to detect early nerve regeneration. And now actually, inshallah, we're actually starting to do clinical trials with all new therapies, which are employing CCM as a kind of primary no-go signal. And we actually in Qatar have done studies now where we used insulin and GLP-1 in people with type 2 diabetes. And what do we show? Well, you give either insulin or GLP-1, what happens? First of all, glucose improves, right? So it goes from about 11% down to about, say, 7%. What do you think happens to their nerves? Actually, these tests that commonly are employed, like vibration and pseudoscan, don't work. But alhamdulillah, the nerves start to repair within 12 months. We now have an ongoing study. This is where I'm actually the favorite. So endocrinology used to be boring, right? But now, whenever I go to a party, when I say I'm an endocrinologist and I say I've got semaglutide or Mounjaro, I'm the most favorite person in the room, right? So we now actually have studies that show semaglutide, beyond lowering weight, beyond improving glycemic control, actually, yes, it does. It lowers weight, it improves HbA1c, but guess what else? It actually repairs nerves. And there is actually an independent mechanism beyond losing weight and glucose, because there are GLP-1 receptors in nerves. So there is something, it's a new story, actually. And as you may know, there are ongoing trials with dementia at the moment. Dapagliflozin, SGLT2 inhibitors, we use them. Do they work for neuropathy? Yes, we've just done a study, from India, where I've collaborated with people, showing that if you reduce HbA1c, it's only marginal, but look what happens to nerve fibers. They start to repair. So SGLT2 inhibitors improve blood glucose, but they also improve neuropathy. And now actually there's been lots of studies, nearly 1,000 patients, multiple different interventions, showing that corneal nerve fiber density, corneal nerve branch density, corneal nerve fiber length all improves with interventions. And these are interventions, whether it's insulin, GLP-1, SGLT2, bariatric surgery, in fact, also as well. So we believe it's a clinical trial endpoint. Oh, how much time have I got left? Oh, okay. That gives me time to show a picture of Ashfaq when he was young and carefree. And I met him in 2014. When I moved to Qatar, Ashfaq moved to Qatar. And, you know, I was kind of not bored with peripheral neuropathies, but I was looking for other things. And then Ashfaq came to me and he said, oh, you know what? Have you ever thought about doing this in stroke? And I thought to being dogmatic, I thought, what? Stroke? What's that got to do with peripheral nerves and cornea? And I must say, it was a good conversation we had at the Hyatt, where he suggested, can we play this? So as you can see, the cornea is not that far from the brain, so it kind of makes sense. So we actually then thought, okay, you know what? Why don't we look at some central neurodegenerative diseases? And in fact, I kind of made that up a little bit because I'd already done a bit of work in Parkinson's disease, which gave me a little bit of confidence that it might work for stroke, might work for multiple sclerosis. But in Parkinson's disease in Manchester, we'd actually looked at patients with Parkinson's disease. And what we found is that there is actually a small but significant loss of corneal nerves in Parkinson's disease. Again, why? You know, everybody thinks about Parkinson's disease as being this motor problem with tremor, with, you know, rigidity. But there was something going on in the corneal nerves that was abnormal. We then actually got a grant from the Michael J. Fox Foundation, and we showed that particularly those patients who are progressing in their disease, they're becoming more tremor, they've got less responsive to drugs. These are the ones actually who have a greater loss of nerve fibers. And with some Chinese colleagues, actually, we've looked at whether or not CCM can differentiate different subtypes. So, you know, there's this tremor predominant, there's other subtypes, so where you've got the postural changes. So we've actually looked at this and shown that we can differentiate the two. So tremor dependent, PIGD, from mixed. And of course, very different from healthy controls. And with high sensitivity and specificity, again, differentiating these different subtypes. Multiple sclerosis. Again, this was something that my then postdoc, Yanis Petropoulos, came to me and said, oh, I just had this great conversation with Sadat Kamran, who's a neurologist, and we think we might be something in multiple sclerosis. And I remember my conversation with him. I said, oh, come on, Yanis, seriously, can't work, right? And you know what? Yes, you can do scans, but CCM actually was able to pick up, particularly the severe MS, complete loss of nerve fibers. And we actually then went on to show that CNFD, CMBD, CNFL was lower, and we got an ECTRIMS grant. And again, with the larger group of patients, showed that in all three, that this is even clinically isolated syndrome, relapsing, remitting, secondary progressive, you can see there's a loss of corneal nerves in MS. And we also then went on to show that actually, not only do you have a loss of corneal nerve fibers, but over time, you can see that in the patients who have secondary progressive, more aggressive form of multiple sclerosis, they're the ones that lose fibers at a much faster pace compared to the top panel. You can see where there's a less of a reduction, and actually loss of nerve fibers or reduction in corneal nerve fiber length change is associated with new gadolinium enhancing lesions, which are the kind of gold standard way of measuring whether or not somebody's progressing. Who's this? Bill Gates, right? Bill Gates was asked to put about 100 million into dementia, right? And he actually went and did this scoping review and said, okay, you know, well, what's the big problem in dementia? Is it new treatments? Is it diagnosis? And what they came up with was exactly what we'd thought about diabetic neuropathy, which is that by the time symptoms show in a patient, when they come to you, it's too late, right? What you need to be doing is you need to be having tests that would diagnose Alzheimer's at the very early onset. So, can we use CCM in dementia? We have used it in dementia. This is actually a study that I did with some Chinese colleagues in Parkinson's disease and dementia. And what we show very clearly is there is actually a loss of corneal nerve fibers, particularly. So this is actually healthy controls. These are Parkinson's disease without cognitively normal. These are mild cognitive impairment, and these are dementia. You can see a progressive loss of corneal nerve fibers. And it correlates with the MOCA score, which is, of course, a marker of cognitive dysfunction. And with high sensitivity and specificity, you can differentiate those who are cognitively normal from those who've got dementia. And over time, actually, we also have shown that if you follow these patients up over 2.6 years, you actually see that corneal nerve fiber density, branch density, and length are as good a predictor of progression as MRI, hippocampal volume, and whole brain volume. Oh, so this is the study actually where over 2.6 years, we took 107 patients with mild cognitive impairment, followed them up, 30% developed dementia, and you can see, there you see CNFD, CMBD, CNFL predict as strongly as MRI changes whether or not the patients develop neuropathy, dementia. And what you see is across the board, all patients who were admitted with acute stroke had less corneal nerve fibers. And that's not because they got corneal nerve damage with the stroke. That is because they had their same risk factors for stroke as they have for corneal nerve damage. Next. What about recurrent stroke? The million-dollar question is, if you have had a patient with stroke, can you actually maybe look at risk factors to define whether or not they're going to get a recurrent stroke? So we looked at this in a cohort of patients with a Schwark. Next. Forget that. Next. So no significant difference in age, BMI, HbA1c, total cholesterol, triglycerides, LDL, HDL, systolic, diastolic pressure between patients with first and recurrent stroke. So all the risk factors that we normally would use, no difference. But next, corneal nerves lower in those patients who had recurrent stroke compared to those who didn't have a recurrent stroke. Next, and coming events cast their shadows before. Next. This is actually a study we did in people with type 1 diabetes, and the simple question we asked was, if you've got type 1 diabetes, you've got severe, like advanced, long-duration type 1 diabetes, you're going to have bad events like cardiovascular events, like MIs and strokes. Can CCM predict those patients? Next. 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 If you look, there are patients who actually have cardiovascular events and strokes. Next. Cardiovascular events, if you look on here, stop working actually. So the next person who comes on needs to be aware that they need to change the battery. CNFD is the only predictor, not age, not gender, not duration, of a cardiovascular event, and stroke. CNFD was the only predictor. Next. Okay. So we've looked at using AI, MCI and dementia, MS and PD. What did we find? Next. We used, again, AI, and guess what it shows? Next. Almost 100% sensitivity and specificity to differentiate PD from MS from dementia, right? So PD, honestly, 100%. When my postdoc came back and showed me this, I said, you got it wrong. You can't be right. Repeated it again. It's right. Next. You can see PD, bottom, 100% sensitivity and specificity for identifying neurodegeneration in PD. Next. Okay, we're there, almost. I did actually have 3-minute warning. Oh, you know, Cash, you've done a brilliant job, but there was one slide I had in there that I wanted to share with everybody, but it was on this thing, but on the stick, but it wasn't there. Anyway, I'll tell you about it. So this is a study we're actually just about to do, inshallah, in Qatar. So it's a study of kids who've been taken out of Gaza, who've been injured. There's about 2,000. The Qataris don't advertise this, right? Because you know what happens if you find that we're being helpful to the Gazans, right? So there's about 2,000 people who've been repatriated, children from Gaza to Qatar, and they're living in a compound. And the psychiatrists came to see me and they said, you know what, we find this strange thing, right? We've got these like three kinds of kids that are coming through, right? One group of kids are kids who just got PTSD, right? Because they've had horrible, events happen to them. And then there's another group where they've lost close family and they get this prolonged grief disorder. But there's this other form. We've not seen this before in any other conflict, right? They've got this resilient form, right? Where they're like, these kids are just unbelievable, right? They said that we cannot believe how they deal with adversity, right? So we got talking, and we actually have now got a project, inshallah, will be funded by Qatar Foundation, where we're going to do imaging. We're going to do fMRI, we're going to do DTI, we're going to do brain, like structural MRI, but also CCM as well, in these cohorts of kids to try to find out what's going on. But also we're going to give them psychological therapy, and we're going to see the response as well. So inshallah, we're going to do that in the next few months, unless Cornell decide to block it. They won't, inshallah. So actually migrated to Australia because my collaborator moved to Australia. Next, and has now grown. Next. And we've now got, actually, there are over like 45 countries. 1 minute. 562 centers worldwide who use CCM. Next. 266 centers who use CCM to study neuropathy. Next. So we believe we can change the diagnostic paradigm for neurodegenerative diseases. Next. So the future to me is next. People, you guys, right? You're walking along. You'll come in. Next. You don't even have to go to a hospital. You could be on the high street. Next. You'll have a CCM. Next. We'll use AI. Next. And we'll say, some of you are healthy. Others, there's something going on. Next. That something could be, next, using AI. Next. Your risk of maybe developing diabetic neuropathy or dementia, or you've already got it and you didn't know about it. Next. I'll finish in the words of Muhammad Ali. He who is not courageous enough to take risks will accomplish nothing in life. That's for the young people and older people, all of you. Thank you.